Hello and welcome. Today, in this video, I am going to talk about imaging in lung consolidation. At the end of this video, you will understand the basic imaging findings in lung consolidation and their implications in making a diagnosis. First, let's talk about what consolidation actually is. We all know that the alveoli are normally filled with air. When alveolar air is completely replaced by other substances, like blood, pus, water, or cells, this is called consolidation. For example, the alveoli are filled with water in pulmonary edema. Here is a list of causes that can lead to pulmonary edema and lung consolidation. Now, look at this chest X-ray. Here, you can see bilateral lung opacities in the perihilar location. This is called the bat wing pattern. Bat wing consolidation shows central consolidation with sparing of the lung periphery. Perihilar distribution is most often seen when there is rapid accumulation of fluid, because vascularity is greater in the perihilar region than in the periphery. Less commonly, this type of consolidation can also be seen in pulmonary hemorrhage, pneumonia, and inhalational lung injury. Similar to water, blood in the alveoli can also lead to consolidation. Common causes include lung contusion, infarction, blood aspiration, and vasculitis. Accumulation of pus in the alveoli as seen in pneumonia and accumulation of cells as seen in malignancy are other causes. Accumulation of lipid and lipoid pneumonia is another cause.
Identifying consolidation on imaging. In consolidation, as the entire alveolus is filled with other substances, it produces a homogeneous opacity. To be visible as two different structures, they must have different densities. When the density of the alveoli and adjacent blood vessels becomes similar, pulmonary vasculature will not be visible. Look at this chest X-ray. Here, you can see bilateral parahilar consolidation. Within the consolidated lungs, vascular markings are not visible. However, in post-contrast images, pulmonary vessels become clearly visible within the consolidated lungs. In this post-contrast CT image, you can see pulmonary vessels shown by the white arrow. This is called the CT angiogram sign. Normally, alveoli and bronchi are both filled with air, so they cannot be distinguished. But in consolidation, since the alveoli have a different density than the bronchi are visible. This is called an air bronchogram. Air bronchogram is typical of consolidation. In this CT image, the black arrow shows a patent bronchus. Bronchi in consolidation are usually normal in caliber, patent, and without distortion. When the bronchus is obstructed, an air bronchogram may not be seen, for example, in cases of cancer, pulmonary infarction, or bronchopneumonia. Therefore, whenever an air bronchogram is seen, bronchial obstruction is ruled out. Another important finding is an ill-defined margin. This occurs because of variable involvement of alveoli at the edges of the disease. However, if the consolidation is bordered by fissures, it can have a sharp margin. Generally, a sharp margin is a feature of a lung mass or malignancy. Another finding is the air alveologram. This is a specific term for non-homogeneous, patchy consolidation with areas of normal alveoli in between. In this CT image, The white arrow shows patchy consolidation, and the black arrow shows loosened areas. Consolidation can present as patchy consolidation and can involve a pulmonary lobule or a group of lobules. In this CT image, some lobules are consolidated while others appear normal. You can see central lobular arteries and bronchi clearly within the affected lobules. Consolidation can also present as central lobular or peribronchial nodules. In this CT image, you can see bilateral, ill-defined central lobular nodules in the right middle lobe. Sometimes these nodules are the sole finding of consolidation, while other times they are associated with larger areas of consolidation. Another key feature is preserved lung volume. Unlike atelectasis, where the lung collapses, in consolidation, the overall lung volume remains constant. Minor volume loss or slight enlargement may still occur. Consolidation usually spreads from one alveolus to another through the pores of cone until it reaches the pleural surface or fissures.
Patterns of consolidation. Once you can identify consolidation, the next step is to understand the patterns of consolidation. These patterns are important to help narrow the differential diagnosis. Consolidation can be divided into diffuse and focal patterns. Diffuse consolidation. Perihilar or bat wing consolidation. This is typical of acute pulmonary edema due to higher vascularity in the perihilar region and efficient lymphatic drainage from the periphery. Less commonly, it is seen in atypical pneumonia, viral pneumonia, and inhalational lung injury. Peripheral or subpleural consolidation. This is the opposite of perihilar consolidation. It is usually seen in chronic pathologies. For example, this chest X-ray shows subpleural consolidation in chronic eosinophilic pneumonia. It is classically associated with eosinophilic pneumonia, but can also be seen in organizing pneumonia, sarcoid, radiation pneumonitis, lung contusion, or mucinous adenocarcinoma. Diffuse airspace nodules. This pattern is typical of endobronchial spread of disease, such as tuberculosis, Mycobacterium avium complex, bacterial bronchopneumonia, viral pneumonia, such as CMV or measles, invasive mucinous adenocarcinoma with endobronchial spread, pulmonary hemorrhage, or aspiration. In this CT image, you can see diffuse nodular opacities representing endobronchial spread in bronchopneumonia. Focal consolidation, lobar consolidation. This involves one or more lobes and is typical of pneumonia. For example, this chest X-ray shows right upper lobar consolidation with bowing of the right minor fissure. This is a case of Klebsiella pneumonia. In lobar pneumonia, the organism spreads from one alveolus to another via the pores of cone until the fissure or pleural surface is reached. Lobar consolidation may also be caused by lymphoma or invasive mucinous adenocarcinoma. In this CT, you can see involvement of the left upper lobe with posterior bulging of the major fissure. Bronchial obstruction due to tumor, lymph node, stricture, or foreign body can also lead to post-obstructive pneumonia or atelectasis, presenting as consolidation. Round or spherical consolidation is most often caused by malignancy or round pneumonia. Round pneumonia is an early stage of bacterial pneumonia that can later progress to lobar pneumonia. This chest X-ray shows round pneumonia due to Legionella. In follow-up, the disease progressed to lobar pneumonia. Segmental or subsegmental consolidation.
This occurs due to involvement of a segmental or subsegmental bronchus or artery. Causes include bronchial obstruction by mucus or tumor, bronchopneumonia, focal aspiration, pulmonary embolism with infarction. In this CT image, you can see a wedge-shaped opacity with the apex pointing toward the hilum. This is a case of segmental consolidation in pneumonia. Time course of consolidation. The differential diagnosis can be further narrowed by the time course of symptoms. Acute consolidation develops within hours. Examples include pulmonary edema, hemorrhage, or acute pneumonia. Chronic consolidation develops slowly over weeks with little change. Examples include chronic infections, organizing pneumonia, or malignancy.